Happy
Excited
to.
for this.
Hey everyone, my name is Kelvin. I'm a third year resident. Thanks for letting me talk today. The topic I chose today is called choice architecture. So some disclosures. I have no financial disclosures. I will say I attended a grand rounds during my intern year. This guy from the UPenn Nudge unit came, Scott Halpern. And we used to have the recording up and I had the link, but UW hid it somewhere. So I don't know where it is anymore. Anyway, so the agenda today is to go over the definitions, like what is choice architecture, the applications in medicine, trying to figure out where do we fit in as residents and why I think we should care about this topic. So choice architecture, it's kind of like mental gymnastics, thinking about how you're gonna put things together in your mind. But the Wikipedia definition is the design of different ways in which choices can be presented to consumers and the impact that presentation on consumer decision-making has. So another way to think about it is the different factors that are going to affect someone's choice, the number of choices, the connotation, the things surrounding it, and pre-selecting defaults. And there's this popular book in the late aughts called Nudge. So you might have heard of this. So simplifying it even more, it's really just how implicit bias affects our decisions. So there's a framework used in medicine frequently that people use to figure out like how much of an impact will the nudge that we're giving either patients or to physicians or staff have. And so the one with the largest impact is default options. So marking and making people opt out. Next would be enabling / active choice. You're kind of having them make a decision based on something you say. Prompt implementation intentions. This one's a little confusing, but it's basically reminders to do something. And then one, the way we frame it, giving info or doing nothing. So the history of choice architecture comes from a couple of hypotheses. I'm not going to read it, but basically the trade-off contrast means you put what you want and then you put something unfavorable next to it. And then the second one would be extremeness aversion. So you put extreme options so that way your option looks much more appealing. So UW specifically has done this, and I don't know if anyone has noticed or even thought about it, but in our order entry, if you type in vitamin D, it used to be alphabetical, and 125 hydroxy vitamin D would go first, but they changed the order of it because we kept ordering the wrong test. Other examples that have been used nationwide are used with opioid prescribing. At Vanderbilt, when they switched their HR system, they took the opportunity because they used to have a calculator that would show the maximum allowed dispense quantity of an opioid. So when someone came in with like a broken leg, like, oh, I want to give them oxycodone, it would tell you, oh, you're allowed to give them this many. And providers would just say, okay, you calculate it for me. I'm gonna give them the max dispense quantity, which makes sense. So they got rid of it. And what do you think happened? Prescription rates went down, obviously. And then similarly, UPenn put in a default quantity of 10 in the ED. So ED providers started just prescribing 10 instead of other values. You can see here, the red bar is how many provider or the percentage of providers prescribing 10 tabs. So kind of going back to how this works with patients, Shri, this would be a poll question. If you were to ask someone with end-stage renal disease in clinic to discuss code status, what percentage would agree to discussing it? What do y'all think? I don't know how to close the poll. Okay, here we go. Wow. All over the map. Okay, let's see. Most people said 30%. Wow, you really think people don't want to talk about this? And in this question, note that they have end-stage renal disease. It's not just your typical clinic patient. But okay, good to know, all across the board. So there's this large randomized controlled trial in Philadelphia where they took 15 dialysis centers, and in the control group, they basically said, "Hey, let's talk about code status and fill out what was essentially a pulse form, or not talk about it." That was a control, because that's typically what we do in our wellness visits. And then the intervention was to give more options. So they said, "Let's not talk about it. Here's a brief sheet of paper, which is basically the pulse. Here's an expanded version, which kind of goes into detail. And then there was a comprehensive form." So with this intervention, meaning more choices, what percentage of people do you think wanted to discuss code status? Cool. All right, so you kind of get the gist. Now everyone says more. Yeah, that's exactly what happened. So the control group, meaning the people who didn't have more choices, about 70% of those with end-stage renal disease said they would talk about it. And then the intervention group switched to 85% with a p-value of 0.004. These are the number of people who wanted to complete an advanced directive, as long as we gave them more options to discuss it. And then by introducing multiple options, you effectively normalize code status discussions, and you suddenly nudge them into wanting to talk about it. But more people didn't actually complete the code status in this study. So they went back to the drawing board and they're like, okay, how do we, what else can we do to influence people's code status discussions? The next study that the group did is they asked, okay, what's going to happen if we fill in a default option during goals of care discussions? So the control group, they didn't fill in anything. And then the different intervention groups is they either put in comfort focus or they put in life extending treatment. And so based on that, you can see this is the percentage of patients choosing comfort-oriented goals of care based on what we selected as a default. And so if we put in comfort care as a default, they were more likely to stick with it. And if we put in life extension as a default, they were more likely to stick with the life extension default. Anisha, I see your comment. I know it's kind of sad. People don't like talking about that stuff. And so they were wondering, well, if we choose comfort care and we switch people to comfort care, are there going to be an effect on hospital-free days? And there isn't, which doesn't surprise me. It just shifts the focus of your care. So I wouldn't take too much away from that study. But maybe we don't need to nudge as many people's goals of care choices as much as we've been told to. But maybe we should, I don't know, not an expert, but just know that the way we word things will influence how our patients make choices. Yeah. So where else have we utilized these clinical nudges in choice architecture? They did this very large study in 2020 before the COVID vaccination came out. And they they took 680,000 clients of Walgreens and they sent them text messages. And reminder texts increased vaccination rates by an average of 2 percentage points over normal. And this next slide will tell you kind of which were the most effective, which I thought was really cool. The one that was the most effective was you have a flu shot waiting for you at this Walgreens. And you see it was almost 3 percentage points. And any message was over or like around a percentage point better than not giving them a reminder. It's progress, Anisha. Cool. So what? Yeah, I know. If you look at some of these, I was wondering like who came up with these texts. It's kind of cool. So what about us? Are we good at understanding common biases? So they did a study at UPenn. They asked 180 residents, only 93 replied, and they gave them a kind of quiz, and they found that overall competence was about 60.6%, which is pretty low if you ask me. So I kind of wanted to see how we did on a few of these. So Shri, this will be a poll. A woman at risk of a genetic disease is seeking medical advice. So the normal quiz takers, they validated this with normal people and then they gave it to the residents. So the first interaction is while waiting, she's asked to write down the age of her youngest living relative. For a different person, while they're waiting, she's asked to write down the age of her oldest living relative. At the start of the visit, you ask her what her own estimated risk is before providing her additional info. So compared to interaction 1, where she writes down the youngest, interaction 2, which she writes down the oldest living relative, is likely to A, increase her estimate of her own risk, B, decrease her estimate of her own risk, or C, not influence her estimate. Yeah, I wouldn't be surprised if this were on step 3, honestly. Cool. Wow, split between A and B. All right, so the answer is she will decrease her estimate of her own risk. And this is based on an anchoring bias. People tend to rely heavily on the first piece of information or anchor when they make decisions. So when they write down the oldest living relative, they think that they're going to live longer. So next, your patient has cancer and you're discussing their options. There are 2 different options you can tell them. The first is you'll need surgery to manage this cancer. You can also seek a second opinion. The second one is you'll need either a laparoscopic surgery. Surgeon inserts cameras and tools through small skin incisions. A robot-assisted surgery. Surgeon controls these robotic arms through small skin incisions. Or open surgery. The surgeon makes a single long skin incision and goes inside. You may also seek a second opinion. So compared to presentation 1, presentation 2 increases the likelihood that the patient will choose A, surgery, B, a second opinion, or C, it won't affect it. No, Shri, sorry, this is also a poll. Oh. So everyone thought that by giving more information, the patient would be more likely to choose surgery, which is actually incorrect. They're more likely to seek a second opinion. And this is based on the multiple alternatives bias. A multiplicity of options may lead to significant conflict and uncertainty, resulting in a lack of a decision or response, or I don't know. Yeah. Thing to remember is this answer is like pretty long and confusing. So people, even though we'll understand it, other people may not. All right, so procedure A usually works and 20% of patients experience a complication. Procedure B may work and 10% of patients experience a complication. The next one would be procedure A usually works to solve the problem, while procedure B may work. Procedure A is twice as likely to cause a complication as procedure B. So as compared to presentation 1, the second one increases the likelihood that the patient will choose which procedure or will not. All right, so pretty split. Most people think they're more likely to choose B, and B is correct. The relative risk bias, people tend to interpret ratios more strongly than percentages. So that's just something to keep in mind. I did not know this. So I think this is the last question. Your patient has a medical condition that can be treated with a medication. So in the first one, you say there's 2 meds, one of them costs $90 a month and it works some of the time, but has a couple of side effects. Second one costs $250 a month, but works most of the time and doesn't really have side effects. The second one is you give 3 options. So the first one, $90 a month. Some of the time it works, but has a couple side effects. Q is $250 a month, works most of the time and not that many side effects. Versus G, which costs $500 a month, works almost all of the time and does not have many side effects. So compared to giving them the first 2 options versus the 3 options, the 3 options increases the likelihood that the patient will choose medication C, medication Q, or it doesn't influence them. Yeah, everyone. Sandwich tactic, I like that. It's called, someone defined it as the compromise effect. A less attractive or less preferable choice increases the attractiveness of another alternate choice. Yeah, so these are the different biases, and I'll come back to the slide, but I just want to show you how the 93 residents did. And we're pretty good at some biases, but we're really bad at like the multiple alternatives bias, anchoring bias, framing and relative risk. And this kind of got me to thinking about medical education and the multiple alternatives bias, especially is we love information, especially as internal medicine docs. But sometimes more information does not help patients. Anisha, I'd love to hear more about that. But, or I guess I'll show you all this. And so all of these have been validated outside of the medical context and have just been recently kind of studied in terms of our practice. So you may have heard of these in a different context. So what does this have to do with us? every day we have discussions with our patients that may have some implicit bias. We have to consider both the ethics of formulating how we frame things, as we know have some effect, and also how to frame them, knowing that we want to, best support our patients. And I think that the best way of thinking about it is in terms of equity. The principles of choice architecture can be applied to help those in most need. And we can nudge both clinicians and patients, whether it be cancer screening, vaccinations, medication prescriptions, things like that. But I also think it can be applied to our medical training. So I think it's, this wasn't a very rigorous lecture, but I thought it was more food for thought for people to think about, man, how can we utilize this information for good, and be more cognizant of how we word things and the effect on people. So these are my references. Does anyone have any questions or thoughts? I really just wanted to get people familiar with this, because this is something that is going to apply to your career every day. And it's something that we can use to, improve things with quality improvement projects, but also market things better and make sure that some of our patients don't get lost.
Calvin.
Thank you so much. Sorry, Lindsay, I cut you off. Thank you so much for sharing this with us. I'm wondering if we think about sort of the reverse of what you're suggesting, that we can nudge people in the direction that we want them to go. What are your thoughts? Isn't this how structural racism works? That like the systems are structured in a way that very subtly, gives different people different options and nudges us. I'm thinking about sort of the race reflected in PFR all the way up to sort of these larger systems level things.
Yeah.
Through your reading, did you see, or do you know about any sort of efforts to analyze this sort of the systems in that sort of light?
Yeah. So there haven't been many studies showing like how systemic racism has affected certain populations in terms of choice architecture, but it's definitely real. I think there's some interesting work from a lot of nudge groups about beefing up medical knowledge. So having like anti-racism lectures in medical curriculum, especially in some of the specialty fields like cardiology. And some fellowship programs are instituting that just to make sure that these gaps don't get widened.
And to respond to Hillary, and Cody's comment, which I think was really pertinent, is it goes back to like who is the architect behind the choices that you're presenting, and the way these choices manifest in structural racism is because the forces behind the way our medical decisions are laid out are manifesting these like systemic factors that are ingrained in our healthcare system. But I think what Calvin is presenting is kind of an exciting opportunity to reappropriate the choices that we present to patients in a more equitable fashion. And some of the like QI work that I think is really interesting is about prompting like equity-driven metrics in the system to say, like, did you notice that your prescribing practices are not equal across these demographics? There's like a movement to do that for like opioid prescribing. There are people looking at like equity of DOAC prescribing, for example, and are more of patients of color receiving warfarin rather than like, higher or more novel medications, instances like that. So I agree, Hillary, that like the way our systems are structured right now leave us vulnerable to present choices that widen disparities, but we can turn it on its head, and the way we build the system can be more actively anti-racist.
Yeah, I think it's important that this information be more widely taught to basically like all med students, because all meds, like some med students aren't, or like are going to become our hospital administrators or our IT administrators, and knowing this information can help set them up with the tools to better understand and help people. And Nick, there are things that institutions do to steer you away from that stuff, and some places will just like put in generic meds by default, even if you type in the brand name, and that's mainly for cost cutting. But cost cutting. But it's hard. Ads are powerful.
Kelvin, one question that I had, kind of going back to the multiplicity of options, is thinking about like informed consent. And when, I am just wondering a little bit about like if what discussion there might be around if we're maybe presenting not like the details of all the options, but sort of more broadly categories of options, and sort of that shared decision making is just something that I was thinking about with that sort of surgery question. And maybe that comes later, but
no, I think that's a very important consideration, is both like health literacy and not overwhelming the patient. And I think that's a very individual decision on how you present. But yeah, I don't know about y'all, but like during my surgery rotation, like the resident would just like go, like speed through the consent, and then patient's like, okay, like, oh, that's kind of weird.
I think an interesting like this clinical instance that comes up is like you mentioned like cancer screening as a common context that we're applying this framework to, and applying like an equity lens to that. Like one of the common things is that we see in like safety net hospital care is a push for fit testing over colonoscopies. And that's something that's built into our EMRs because the capacity is so much higher for fit testing. But when you ask physicians like what they would choose for themselves, most of them will say, I want a colonoscopy every 10 years. I want a thorough look. So there's like an inherent equity implication and when there's an opportunity for choices. So like when patients get to choose between two options for cancer screening, our EMRs we end up building in inherent choice for certain types of patients. And a similar circumstances when there's an opportunity for shared decision making. So prostate cancer screening or early breast cancer screening for women between 40 and 50. Those are opportunities where the EMR can't really factor in shared decision making. So there's an opportunity for more inequity in those areas.
Yeah, and I think a lot of this will also go to the research. So this text message notification thing by Walgreens, even though it went to 680,000 patients, there are subgroups and certain subdivisions, and there's a lot of things that weren't studied, and because they weren't, we're applying things broadly to populations that shouldn't have things broadly applied.
Something that I've seen from my own experience is that decision making is it's a learned behavior, in that with time and with you building a relationship with someone, patients approach it differently. And I think it's important to keep that in mind and say, hey, maybe this is something that needs to be taught, or people need to be empowered in the beginning, so that down the line, they are able to not only make decisions with you, but also feel able to make decisions with others that they don't know in the healthcare system.
Oh man, don't get me started on Facebook. Facebook is probably the worst organization with in terms of nudging. That is my presentation. If you want to know about consumer sleep technologies, I apologize. I can send you those slides if you want. Basically, if your patients are using something and it works, just let them keep doing it. Nothing actually helps that much.
Awesome, everyone. Well, this was a great talk. It left us with a lot to think about. Feel free to send Kelvin questions if you have them, and keep talking about this with your patients. And then we will see you next time on Thursday for Academic Half Day.